Dr. David Morley, who in his book called Priorities of Pediatric Priorities in Developing Countries, he said for management of diarrhea, one should know at least 5 days, starting from diagnosis, dietary management, dehydration correction, drugs, and treatment of disaccharide deficiency, 5 days. So this has been changed to Zodiac. Zodiac simply stands for, Z stands for zinc, O stands for ORS, D is diet, I is immunization, A is antibiotic, and C is cleanliness. So I will just talking about this. As you know, when you come to the diagnosis of a child with diarrhea, one should know whether the child is having an acute watery diarrhea or dysentery, because the antibiotics are given only in children with dysentery. What is diarrhea? The WHO has defined diarrhea.
Sir,
If a child possesses, yes,
slide share sir.
slide is
Yeah.
not there. You are not seeing the slide.
No.
Okay. Slide sharing.
Okay, sir.
Okay, right.
Okay.
What is acute diarrhea? Acute diarrhea is a diarrhea of acute onset, which usually lasts for 4 to 7 days, but sometimes it can last up to 14 days. So diarrhea less than 14 days, we call as acute diarrhea, and diarrhea lasting for more than 14 days, it is a persistent diarrhea. What is dysentery? Presence of blood in the stool is called dysentery. Presence of macroscopic amount of blood in the stool is dysentery, and those children with dysentery should be treated with antibiotics. Now coming to the role of zinc, our state president has already talked about the role of zinc for treatment of diarrhea. It is seen that the zinc can reduce the frequency of diarrhea, and it can also reduce the duration of diarrhea. As you all know, zinc has got an immunomodulatory effect is there, and it is seen that now more than 50% of children in developing countries will have zinc deficiency, which can be aggravated by zinc. So all children with diarrhea should be supplemented with zinc. But unfortunately, all the studies shows that less than 15 to 20% of children receive zinc. Which zinc to be given? There are various zinc salts are there, zinc sulfates, zinc gluconate, zinc acetate. Any zinc preparation can be given, any zinc, with zinc alone. And you should not combine zinc with the B complex vitamins, or you should combine zinc with iron. And the dose of zinc, as you all know, in children less than more than 6 months, you must give 20 milligram, and less than 6 months, you may give 10 milligram, and it should be continued for a period of 14 days. So if you give zinc supplementation for a period of 14 days, you can reduce the recurrence of diarrhea in the next 3 months. So it can prevent the recurrence of diarrhea if you supplement zinc. So zinc should be supplemented for all children with diarrhea. Then all the speakers has highlighted the importance of ORS. So I'm not going the details of ORS. ORS is the most important discovery of this century. As you all know, ORS can be used for prevention and treatment of acute diarrheal disease. And the main effect of ORS is, the main principle of ORT is the glucose enhanced sodium transport. Glucose will enhance the sodium transport across the epithelial cells. And it is given for children with no dehydration, some dehydration. In severe dehydration, we should follow the PAN C, IV fluid is given. Regarding IV fluids, I just want to highlight one point. The IV fluid of choice should be ringer lactate or normal saline. Don't use a maintenance fluid for treatment of diarrhea. No use of maintenance fluid. Isolate P should not be given for treatment of acute dialysis. Not only for treatment of acute dialysis. In a PICU setup, no, but there is no indication to give a maintenance IV fluid for treatment of any medical problem. So for the treatment, the IV flow of choice should be ringer lactate or normal saline. I don't not go into the details of fluid therapy. So ORS should be prescribed for all children with diarrhea. Unfortunately, as Dr. Sulega has said, ORS prescription is seen only in 50 is given only 50% of our children with diarrhea. Then coming to the diet in diarrhea, Dr. Savita was talking about diet. You should not stop any diet for children with diarrhea. All previously taken diet should be continued. It is seen that absorption of protein, absorption of amino acids and fat is not restricted in children with diarrhea. So there should be given additional calories and proteins for the regeneration of the epithelial cells. So more calories should be given. And coming to milk, all children who are on breast milk should be continued. And also those children who are taking a cow's milk, the cow's milk should be continued. And one problem people always talk is regarding lactose intolerance. It is seen that the lactose intolerance in a child with diarrhea is only transient. It's only transient lactose intolerance. It may last for 4 to 5 days and it can subside spontaneously. So even if there is a sugar is present in the motion on examination, this not lactose intolerance is not an indication to stop milk in a child with diarrhea. The only indications for stopping breast milk are if a child is having severe lactose intolerance, if the child is not gaining weight or the child is losing weight, and if there is diarrhea is lasting for more than 2 weeks, you may stop breast milk or cow's milk temporarily. So again, I want to highlight that lactose intolerance in a child with diarrhea is only temporary. These children should be given additional calories and proteins to prevent malnutrition in these children later. Then coming to immunizations, rotavirus vaccine has revolutionized the prevention of diarrhea in children. As you all know, rotavirus vaccine, two types of vaccine is available. Monovalent vaccine is there, pentavalent vaccine is there. Monovalent vaccine, 2 doses are given. Pentavalent vaccine must give 3 doses. According to the national schedule, even rotavirus vaccine is given in almost all states now. You must give 3 doses of rotavirus vaccine at 6, 10, and 14 weeks. It should be done. And the efficacy of rotavirus vaccine is nearly 80 to 50%. So it should be given for all children to prevent acute viral disease. And also, measles virus infection can be prevented by measles vaccine. And measles vaccine can produce severe watery diarrhea, and also it can produce a persistent diarrhea. When you discuss about the drug treatment of diarrhea, the least important one is antibiotics. Antibiotics are the least important in the treatment of diarrhea. But it is seen that in more than 60% of children, antibiotics are prescribed. What are the indications for giving antibiotics? Antibiotics are indicated only in children with dysentery. If a child is present with dysentery, that means if there is blood in stools, if there's a macroscopic amount of blood in stools, you can start antibiotic. The antibiotic of choice, the WHO recommends ciprofloxacin as the antibiotic of choice. Ciprofloxacin, and it should be given the dose of 15 milligram per kilogram body weight 12th hourly, only for three days. The other antibiotics may be cefixime, or in children with severe dysentery, you can give ceftriaxone. And now the recent studies have shown that some of the Shigella has become resistant to these drugs. So the upcoming drug will be azithromycin in the dose of 10 milligram per kilogram body weight should be given for 3 days. Previously, we were giving a subtran, nalgesic acid, and Shigella has become resistant to almost all these drugs. So drugs should be either a cefixime, ceftriaxone, or azithromycin. Regarding watery diarrhea, in a child presenting with a watery diarrhea, the only indication for giving antibiotic is those children with the diagnosis of cholera. but cholera can be a clinical diagnosis. A child who is older child presenting with severe dehydrating diarrhea with rice water stool, then you diagnose cholera in this child, and the drug of choice for cholera may be doxycycline, erythromycin, or Septran. This drug can be given. Then regarding the treatment of amoebiasis and giardiasis, amoebiasis is very, very rare in children. It's very rarely seen in children. You suspect amoebiasis in a child who is presenting with dysentery. If a child presenting with dysentery has received two doses of two separate doses of an antibiotic, if after receiving two antibiotics, if the dysentery is persisting, then you should go for a motion microscopy. And in the motion microscopy, you must look for vegetative form of amoeba, not cyst. If vegetative forms are there, you can give metronidazole in the dose of 5 to 10 milligram per kilogram body weight for 5 to 10 days. And also giardiasis may sometimes present with dysentery. You can give metronidazole or tinidazole for a period of 5 days. Regarding some of the other antibiotics, antibiotics of no use in the treatment of diarrhea will be amoxicillin. Ampicillin may be effective to some extent in a child with Shigella. But as you all know, the main difference in the therapeutic spectrum of ampicillin and amoxicillin is not sensitive in children with shigellosis, so it is not going to be effective. And also, aminoglycosides are not effective for management of diarrhea. First generation cephalosporin. Other drug is neomycin. Neomycin should not be given for treatment of diarrhea in children, can produce a secondary lactose intolerance. So then coming to other drugs, antiemetics, there is no role for antiemetics, but even the newer WHO recommendations say that you can give a single dose of ondansetron. Single dose can be given. The dose of 0.1 milligram to 0.1 to 0.2 milligram per kilogram body weight. As a single dose, it can be given. But it is reported that it can produce some cardiac problem, especially QT interval prolongation is reported with ondansetron. So it is not indicated. Some of the drugs like antimotility agents like Lomotil, loperamide was used previously. You should not give antimotility agents, especially Lomotil. It is toxic. These antimotility agents can reduce the motility of the intestine. More fluid will be retained in the intestine. More organisms will be retained. They will not produce more toxins, and diarrhea will be aggravated. And diphenoxylate can produce problems like CNS, depression, seizure, coma, and death, and paralytic ileus. So there is no role for these drugs. And yet another drug is resicotrotryl, which is an encaphelinase inhibitor, and there is no much role for resicotrotryl for treatment of diarrhea. So I just want to highlight that antibiotics are given only for children with dysentery, and those children with severe watery diarrhea. If you make a diagnosis of cholera, you can give doxycycline for these children. Then cleanliness is very, very important. As you know, in this time of COVID, we are following the SMS, social distancing, sanitizer, and masks. If you are using hand washing, you can prevent a lot of children developing diarrhea. And also because of this, one of the most positive effect of our hand washing is that it can reduce the incidence of acute watery diarrhea. So it should be implemented. And also, as I summarize this talk, when you treat a child with diarrhea, definitely you must follow what is called zodiac. Zodiac is very, very important. And don't prescribe gastro. You may be wondering what is gastro. GASTRO. G stands for gentamicin. A stands for amoxicillin. S for Saccharomyces boulardii. T for tinidazole. R for resicotrotryl. And O. You can guess what is O. What is O is? Unfortunately, it is not ORS, it is ofloxacin. So prescribe only zodiac and not gastro. One more point I want to highlight among drugs which just left was about probiotic and prebiotic. Dr. Anandavasan was talking about probiotic and prebiotic. There is no much role for probiotic in the treatment of diarrhea. We are having a talk by a gastroenterologist. Actually, the reason literature say that the role of probiotics, it depends on the strain of the probiotic, the dose of the probiotic, and duration of probiotics. There are only mainly 4 probiotics are found to be have some effect. I don't exactly remember the name of the probiotic, especially Lactobacillus GG and Saccharomyces boulardii may have some beneficial effect in the management of diarrhea, especially in the treatment of diarrhea induced by antibiotic-induced diarrhea. In antibiotic-induced diarrhea, there may be a mild role, small role for probiotics. Otherwise, there is no role for probiotic in the routine management of diarrhea. So again, I want to highlight the importance of 3 things. You must start with ORS, zinc, and good nutrition for the proper treatment of children with diarrhea. Thank you very much for your patience. If there are some questions, I will take the questions now.
Thank you, sir. There was one question in the chat box. That is the lowest age at which ciprofloxacin can be prescribed to a child with dysentery.
See, actually, regarding ciprofloxacin, according to the FDA, ciprofloxacin should be judiciously used. It should not be prescribed for children less than 18 years. That is what the FDA say. But it is seen that all the quinolones, including ciprofloxacin, they were used for a very long time for treatment of children with cystic fibrosis. And children with cystic fibrosis was received ciprofloxacin and other drugs. No cartilage toxicity was seen. The main problem concerned with ciprofloxacin is cartilage toxicity. But now it is seen that the cartilage toxicity is species specific. It is seen mainly in experimental elements. In human beings, cartilage toxicity is not seen. It's not reported. So you can use it judiciously. The word judicious use should be there. It can be used judiciously in children less than 18 years old. It can be used. But for treatment of dysentery, the WHO said it should be given only for 3 days.
Thank you, sir. If there are no more questions, we'll proceed on to the next session. Thank you, Sukumaran sir, for the wonderful and excellent talk. Now I invite Dr. Jagadish Menon, consultant pediatric gastroenterologist and hepatologist from Chennai, for his talk on acute liver failure. Welcome, Dr. Jagadish.
Share one. Hello.
Hello. Yeah. Hello. Good evening. Good evening.
Good evening.
Yeah. So first of all, I would like to thank the Kerala IAP and the Kottayam IAP for giving this opportunity for discussing a topic in the forum. So the slides are visible.
Yes.
Yes.
Okay. So the topic of discussion will be acute liver failure in children, in fact. So first of all, I would like to start from the history, like the Greek mythology. It says the liver, it is known as the hepa. They thought it is the site of life. And these were 2 Greek legends, like the Prometheus and the Theseus, who were like sentenced to death by eating of the liver by eagles and vultures. So they initially thought that it's the site of life, and when the eagle and vultures eat, these people will die. But subsequently, what this diagram actually depicts is the massive regenerative capacity of the liver. So every day when the eagle and the vulture used to come and see, the liver would have regenerated. So there is an amount of regeneration that happens in the liver But subsequently, there is a time point in which the regenerative capacity exhausts, and at that point, the liver fails. So the time we call it as a liver failure. So this is the format of my talk, in which I will be talking about the definition, pathophysiology, etiology, supportive management, and the definitive management of acute liver failure. So just highlighting what is new in ALF, there are a lot of definitions in acute liver failure. There are some specific scenarios in ALF we need to discuss. Supportive management, what is new? And regarding the liver transplant, regarding the auxiliary versus a conventional transplant. And there is a role for hepatocyte transplant also. This will be highlighted in the discussion. So, first of all, regarding the initial definition that we had, so the massive liver necrosis, which is associated with the encephalopathy, which is developing within 8 weeks from the sign of illness, was defined initially as acute liver failure. But in children, the encephalopathy is difficult to analyze, stage 1 and 2. Maybe rather more for stage 1, it is difficult to analyze stage 1. Then subsequently, we have this syndromic definition in which multisystemic disorder in which acute impairment of liver function with or without encephalopathy came in association with hepatocellular necrosis in a patient with no underlying chronic liver disease. So this includes a clinical definition. You have a pathological definition here, hepatocyte necrosis, and a radiological thing. You have a chronic liver disease or not. But again, this didn't specify the timeline in which this happens. So subsequently, the King's group from London, the OGAD group, actually classified it into an hyperacute, acute, and a subacute liver failure, starting from the jaundice to encephalopathy. Whatever is happening in the initial week, we call it a hyperacute liver failure, in which we have a raised ICP more, followed by an acute liver failure spanning from 1 to 4 weeks, and followed by a subacute liver failure, followed by the other definitions. Since in children, the problem is not tackled because of the time span, we have the PLF study group, which has based this classical definition for acute liver failure. Timeline we take is totally 8 weeks. So that is, it actually starts with a biochemical evidence of acute liver injury and a liver-based coagulopathy, which is defined as a PT that is greater than 15 seconds or an INR greater than 1.5 with hepatic encephalopathy, which is not corrected by vitamin K. Corrected means at least we should give 6 hours for the vitamin K to act. And the earliest, if you want to decide for something like a transplant, is 2 hours actually. Or if there is no plus or minus hepatic encephalopathy, if the INR is more than 2, it fits into the criteria for acute liver failure. And there should not be any evidence of an underlying chronic liver disease. So liver-based coagulopathy, I've highlighted here the factors which are vitamin K dependent. So factor 7, which has got the shortest half-life, if it is exhausted, the extrinsic pathway will be affected and you have the prolongation of PT and INR. So that is the basis of the definition. Coming on to the pathophysiology of acute liver failure. So the liver is the central organ of various metabolites and inflammatory substances and even toxins. So whenever you have an initial event of something like an infection that is happening, you have something like toxins which are released from the liver. So it includes both hydrophilic and hydrophobic substances. Hydrophilic are ammonia lactate. Hydrophobic are basically the bile acids and the lipid reactive oxygen species is what happens. So once it is relieved, it's a storehouse of all these metabolites, which actually gets released into different organs in the body. And we can see that there can be endocrine dysfunctions, which includes the brain, kidneys, cardiovascular system, bone marrow, etc., which again causes a vicious cycle. So this liver is entrapped in a cycle. So all these cytokines again will impair the regenerative capacity of the liver, again causing the things to go down. So that is how the liver failure, the cascade actually happens. This is a model of liver failure I would just like to mention here. So the red thing are basically the hepatocyte. We can see the fraction of the liver that is remaining. Whenever you have 100%, 90% liver, you have everything that's going fine. But when you have a 50% of the liver that is exhausted, the enzymes have started going up here. Still, the INR is holding on. Again, the 40%, the INR is started getting abnormal. So once the INR starts getting abnormal, you actually find here that at the 40% of hepatocytes are remaining, the rest is gone. Subsequently, This is the most important stage in which only the 1/4 of the liver is remaining, in which you have an INR that is more than 4. The bilirubin has gone up. Most probably it is at more than 15 to 17, in which the child may require liver transplant. It becomes a criteria that we'll be discussing later. Coming on to the etiology of liver failure in children, we all know that the most common etiology is a viral hepatitis, more hepatitis A, more than E, more than B, and other non-A, non-B, and non-E hepatitis viruses. Metabolic liver disease, Wilson, I would like to highlight separately because it's an important thing, even though it's a metabolic liver disease. Autoimmune hepatitis rarely, drugs, especially in our setting, ATT. In the West, it is acetaminophen, but in India, it is more an ATT-induced liver failure. Ischemia, toxin, HLH, malignancies, Budd-Chiari syndrome, acute Budd-Chiari, and hepatic resection. And there are a fraction of causes which are indeterminate, but because of the increasing awareness and increasing investigation, this fraction of indeterminate part is getting lesser. So this is the largest experience part we have initially from the King's College group, in which we had like we can see here that there was a large fraction of indeterminate group here. So the study was done from 1990 to 2003. So large group here, but we can also equally see that the drug induced, in which acetaminophen is the commonest cause there. Other causes included viral hepatitis and also a metabolic cause. And Wilson, we can see here separately. So from India, we are having two important studies. One is from Chandigarh and other is from New Delhi. So from Chandigarh, there were 67 children with acute liver failure, and majority were hepatitis A. And they have seen that the outcome becomes bad when they have an advanced HE. Bilirubin is very high. There is an evidence of AKI. And if it is more like a subacute presentation, slow smoldering, increasing jaundice with liver failure. In IAP study, they have seen that, again, the viral hepatitis was the commonest cause. And they have also seen that the pediatric end-stage liver disease score at 72 hours could say that the child can perform worse. Sorry, it's getting... Sorry, it got stuck, I guess. I'm just opening it again. Okay, so coming on to the etiologies of acute liver failure, just describing about the viral hepatitis. So in hepatitis A virus, the risk of developing an acute liver failure is very less. It is less than 1% virtually. And we have to remember that in at least 95% cases, anti-HIV IgM will be positive. Rest 5% will have this thing on repeated testing. And HIV infection, the risk of developing acute liver failure is 0.6 to 2.8%. In hepatitis B infection, which is in acute hepatitis B, it basically happens when there is a reactivation of the infection, seroconversion that happens, and vertical transmission from a mother who is positive for HBsAg. And we have to always do an IgM anti-HBC because many a times the HBsAg may be negative because massive hepatocyte necrosis, so HBsAg may not give a clue. And hepatitis C virtually doesn't cause liver failure. HSV is another important cause in neonates, as we know. Seizures indicates neurological involvement. There can be jaundice and grossly elevated enzymes, and we can have an 85% mortality that is there in this case. Hello. Yeah.
It's not moving.
Yeah, it's not moving actually.
No. I think you can exit and come back.
Yeah, now it has started. I think it's.
Yeah, okay.
Yeah. So coming on to the metabolic causes, galactosemia becomes an important cause in infancy, which is due to galactose 1-phosphate transferase deficiency. The most important manifestations are deep jaundice. You can have hemolysis. There can be a gram-negative sepsis because high galactose actually causes a neutrophil dysfunction. There can be oil drop cataract, and usually they have new normal enzymes. And GALT assay and genetics are basically needed for diagnosis, and lifelong galactose-free diet is needed. And early diagnosis is actually cornerstone in treatment of galactosemia. So tyrosinemia, it is a defect in Fa enzymes. It is due to the femoral acetoacetate and malonyl acetoacetate accumulation. Succinyl acetone in urine is diagnostic of this condition. There is a medical therapy that is known as NTBC, so which can delay whatever cirrhosis or HCC that is happening in the liver. And a fraction of these patients will land up in a liver transplant. Urea cycle disorders, mitochondrial disorders can also rarely cause liver failure. Neonatal hemochromatosis is a gestational unleavened disorder, which can actually lead to an acute liver failure. Anyways, this entity needs to be diagnosed early. They masquerade sepsis, and once it is diagnosed, the treatment of choice is intravenous immunoglobulin. Coming on to Wilson disease, it is a commonest metabolic disease in children, apart from infancy, in fact. So it's an autosomal recessive disorder which presents with Coombs negative hemolytic anemia. Typically, we have a low serum ceruloplasmin, but that is not seen in around 1/3 of the cases. Low alkaline phosphatase can give a clue. We have to remember that the autoantibodies like ANA and SMA might be reactive in case of Wilson disease. Biopsy is not always feasible because the child has a deranged coagulogram. And the dictum is Wilson in ALF. If there is hemolysis associated, the child will almost land up in a transplant. So once we have a child who has come to us with an underlying liver disease, we need, with an acute liver failure, we have to see whether the child has an underlying liver disease. So underlying liver disease, first of all, we have to see the child. The child has any clinical features of cirrhosis. So we know the cutaneous stigma of cirrhosis the child is having. If the child has a splenomegaly, that is a clinically detectable splenomegaly. If the child has an ascites, moderate to massive ascites, and ultrasound is showing a quiescent necrotexture of the liver, we have to think of an underlying chronic liver disease, which is an acute, and maybe the presentation is like an acute on chronic liver failure rather than an acute liver failure. So coming on to the different presentation of acute liver failure. So it happens with jaundice, seizures, altered sensorium, or bleeding. And the death in acute liver failure, usually the commonest cause is sepsis. There can be raised ICP. It can be due to a DIC or a bleeding or a multi-organ dysfunction syndrome. So coming on to the management of acute liver failure. So coming on general management, etiology-related treatment is different. Management of specific complications can be there, and there can be an indication for transplantation. Coming on to general measures. So we have to nurse the child in a quiet environment. Sedation should be typically avoided because many of the sedative agents can progress hepatic encephalopathy or masquerade the progression of hepatic encephalopathy. Transport to a liver transplant center is when the child has worsening coagulopathy or any onset of hepatic encephalopathy, then we anticipate a liver transplant. And encephalopathy, any grade of encephalopathy or an INR that is greater than 4, the child should be admitted in an intensive care setting. So this is the timeline of like monitoring, frequency of monitoring. Vital signs at least 4 hourly. The patient is more sick, we need to tailor it, but this is the minimum frequency in which we should monitor. There should be a neurological examination, electrolyte, ABG, and sugars twice daily. INR should be done twice daily. And clinical examination is also necessary. We need to see whether the liver is shrinking because of necrosis. We need to do the LFT, the renal functions, calcium and phosphorus at least twice a week. Coming on to ventilation, assisted ventilation, the main indication is airway protection. So if the patient has an advanced grades of hepatic encephalopathy, or the patient has a respiratory problem, hypoxemia, secondary sepsis, ARDS, hemorrhage, or any volume overload, we need to intubate the patient. So these are the agents which I've highlighted in, for helping in intubation: skeletal muscle relaxants, the sedative agents, and also the analgesic in that order. So we should not allow the child to deteriorate and then have an aspiration and intubate. So it should be an elective thing if the child is rapidly worsening in the encephalopathy portion. So endotracheal intubation should be done with a cuff tube and with a one go. And it should be done with minimum struggle, because any movement or any stimulus can lead to raised ICP and lead to herniation of the brain. So these are the parameters in ventilation that we need to keep. But our tidal volume 5 to 8 ml per kg should be kept. Avoid hypoxemia, because hypoxemia can lead to a raised ICP. To maintain a saturation of greater than 96%. Normocapnia should be maintained actually, because high CO2 again leads to raised ICP. There is a debate on transient hyperventilation when it should be applied, but latest consensus says that it does not have much role except in case of an impending herniation. So in that case, only we do a transient hyperventilation. It should be transient because if we hyperventilate more, there can be hypocarbia, which again leads to a vasoconstriction causing cerebral anoxemia. So fluids, 2/3 of the maintenance fluids, but there is no definite consensus. We have to look for dyslitolemia. The target sodium we maintain is from 145 to 150 milligrammes per liter. Supportive measures, the nutrition, usually NG feeds is encouraged. If not, TPN should be started. The blood sugars should be maintained between 100 to 180 mg per deciliter. The GAR I've already mentioned, it is 8 to 9 in infants, 7 in toddlers, and 4 in adolescents. The IAP guidelines mention a GAR starting of 8. So role of protein restriction, there is no role in fact, except when the patient has hepatic encephalopathy. Sucralfate and ranitidine can be used so as to decrease the incidence of GI bleed. Role of antibiotics. So incidence of sepsis in liver failure, if we are not starting any antibiotic prophylaxis. Bacterial sepsis, the incidence is around 82%. Fungal sepsis, 1/3 of the patients can have fungal sepsis. We all know that there is, because of the inflammatory storm, there can be an SIRS which happens. That happens in around 60% patients. And we know that the importance of this is, if the patient has a sepsis, the chance of progression to hepatic encephalopathy happen in virtually 80% of the patients. So the indications for starting an antibiotic in case of acute liver failure. So advanced hepatic encephalopathy 3 and 4. If the patient has an SIRS, patient who is listed for liver transplantation, regarding that is irrespective of stages of HE, the patient has an AKI or a refractory shock. And in case of infants, obviously we need to start on acyclovir, because the mortality with an HSV liver failure is very high. Tackling the coagulopathy, vitamin K daily dose should be given 5 to 10 mg. Some consensus says only single dose is necessary. Thrombocytopenia can be worrisome, especially if we are anticipating any invasive intervention or procedure like a central line. So platelet count 10,000 or if less than 50,000, we have to transfuse PC. Cryoprecipitate is given if fibrinogen is 100, and if there is active bleeding. FFP is given when invasive procedure or any active bleeding that is there. Recombinant factor 7, it is difficult. There is difficulty in availability, but it can be used when there is a volume overload. Vasopressin, which should be used, the first vasopressor obviously of choice is noradrenaline, followed by vasopressin. Adrenaline should not be used because it decreases the mesenteric circulation and it can lead to hepatic hypoxia. So, encephalopathy of acute liver failure. This is a beautiful topic because why the hepatic encephalopathy in ALF is more dangerous than that of cirrhosis? This is because of the two reasons. The first reason is that in a hepatic encephalopathy, chronic liver disease, the osmolality has been already adjusted by the body. So in that case, the osmotic load causing cerebral edema, the incidence is less. Second reason is that in a child with a chronic liver disease, you have an underlying cortical atrophy. So there's a space for the brain to expand into the skull. So HE in ALF has higher chances of getting a cerebral edema and subsequently can lead to a herniation. So the PLF registry, which says that in total spectrum of ALF, half of them had hepatic encephalopathy and 3/4 were in stage 1 or 2, that is in the early HE. We have to remember that ammonia lowering agents, protein elimination, lactulose, gut decombination, and branching amino acid does not have any role in acute liver failure. These agents have role only in decompensation, recurrent decompensation in chronic liver disease. Coming on to raised ICP, it is defined as a value greater than 20 millimeters of mercury. So it is known that an ammonia value that is greater than 150 is associated with the raised ICP. So the risk of cerebral edema is higher in the younger age group. Signs of raised ICP, you have to start on hypertonic saline and mannitol, but no role for any prophylactic hyperventilation, mannitol, or steroids. 3% NaCl can be given to target a sodium between 145 to 150, and this has been shown in some studies to decrease the incidence of cerebral edema. So these are the doses of 3% NaCl and mannitol. Mannitol, we need to remember that we need to check for the osmolality. So osmolality, if it is going very high, if it is going more than like 320, we won't be able to give mannitol. And one important thing is the mannitol, because of the severe diuretic effect, can cause hypotension and is contraindicated in an acute kidney injury. So renal failure, around 18% of like patients with ALF has acute kidney injury. And the paracetamol poisoning, around like 3/4 will require a kidney support and a renal support, like a dialysis. So renal replacement therapy, this is one of the important cornerstone as like bridging in acute liver failure. The main indication is when the ammonia goes up. So if progressively increasing ammonia more than 150 or a single value that is greater than 200, that actually indicates that the child will require an RRT. This is to decrease incidence of cerebral edema and herniation. Rest are the indications that are seen in an acute kidney injury that happens along with this. Also, in an advanced stage of hepatic encephalopathy, it is recommended, this basically from the King's College recommendation, as a bridging therapy before a liver transplantation. There are a few emerging concepts. One condition is known as hepatoadrenal syndrome. We know that there are conditions in which, like hepatorenal syndrome, in which a liver injury which lead to a possible reversible renal function, but not always. But we now know that the cytokine release from the liver will suppress the adrenal, which will add on to the shock in ALF. So in that case, steroids have a role in case of a refractory catecholamine resistant shock. Seizures are seen in 10%, and EEG is indicated. We have to monitor in stage 3 and 4 HE. But there is no role of any seizure prophylaxis. CT head, sudden decline in sensorium, or if there is any features of Falcon signs, we have to do a CT. That is basically to rule out an intracranial bleeding. And use of ICP catheters, there are a lot of studies on the use of ICP catheters, which helps to monitor an ICP. But the thing is, it is basically a controversial, since there is high incidence of first intracranial bleeding, and second, they can have increased incidence of sepsis. So it is basically controversial. Coming on the role of hypothermia, is found to be effective with lowers ICP. The temperature that has been found to be effective is 34 to 36 degrees. So coming on to the definitive management. So etiology-related treatment. So I have already discussed neonatal hemochromatosis, IVH, is the treatment of choice. Autoimmune hepatitis, steroids, methylprednisolone or oral prednisolone can be used. Tyrosinemia, NTBC has a role. galactosemia, if diagnosed early, a galactose-free diet can be instituted, and the child will start showing a clinical response as early as 48 to 72 hours. Herpes infection, acyclovir, paracetamol, we obviously know N-acetylcysteine has a definite role. Hepatitis B infection, associated ALF, entecavir has a definite role. And this is a new finding which has been seen in HCV-associated acute liver failure. The EASL guideline says that ribavirin, if used, will decrease the incidence of mortality in hepatitis E infection. So that has come up in the guidelines in 2018. So coming on to the NAC in non-acetaminophen toxicity, so we can see that in adult study, it has found to be a marginal benefit in use, but in children, it is not useful, and maybe sometimes in the long term, it decreases the survival. So N-acetylcysteine is not to be used in non-acetaminophen pediatric acute liver failure, and more trials are required in this aspect. This just mentioning the extracorporeal liver support system, it basically removes the toxins, free radicals, prostaglandins, etc. Can be artificial or bioartificial. It can be used as a bridge to liver transplant, and it can decrease mortality without a transplant in around 15% to 17%. That is as per latest meta-analysis. High volume plasma exchange. This we do when the patient has active hemolysis, and obviously, usually it is associated with Wilson. Sometimes we can have an acute liver failure secondary to hepatitis A with a J6 period deficiency where there is a hemolysis. That case also it will be helpful. Or sometimes when you want to correct coagulopathy without a volume overload, we start on plasma exchange. So there is some survival benefit, but long term it is not there. So choosing the right path. So when to transplant, because it is seen that around 50% of the total spectra of ALF will finally end up in a liver transplant. Traditionally speaking, we started with the King's College criteria, but this is feasible in kids only for acetaminophen toxicity. For the other etiology, this does not stand in children. So in children, so when to transplant? So this is the criteria. So this first came from Clichy in France, and now it has been adopted by IAP, and this is followed worldwide. An INR greater than 4 and a factor 5 level, or a factor 5 level that is less than 25% becomes an indication for a liver transplant. So if, for example, we are having 100 kids who are listed for transplant, we know that around 80% will be successfully transplanted. 10 may have a reversal. So that happens when they have a delay in getting transplant. So 10% may have a spontaneous recovery, and 10% may have a logistic issue during transplant, which can, like before transplant, what I mean, which can lead to mortality. So 80% would make it. So this is a new Wilson index, which is used for Wilson disease. It is available over the web. Any score that is greater than 11 or more than or equal to 11 indicates that becomes an indication for liver transplant. Autoimmune hepatitis in acute liver failure with HE almost always requires a transplant. Methylprednisolone usually doesn't help. Tyrosinemia, if not responding to NTBC, there are a few contraindications to liver transplant. If it is an uncontrolled sepsis, I would like to mention it is an uncontrolled sepsis, extrahepatic malignancy, if there are signs of cerebral herniation and a multisystemic mitochondrial disease or an HLH, in which a transplant won't be helpful because there are extrahepatic organ that is involved. Coming on to the liver transplant, we have the split liver grafts. So initially we used to have the orthotopic or the whole liver transplant, in which the donor, part of the donor liver was implanted into the recipient, in which the liver would grow and make the function. But this is a novel thing, which is known as the auxiliary liver transplantation, orthotopic liver transplant, in which the native liver is left behind. We are not removing the native liver here. We are keeping the donor liver. We are implanting the donor liver to the blood vessels in the recipient's body. And we give some time for the recipient native liver to regenerate. So in some cases, the regeneration may not happen, but in maybe around 50 to 60% cases, the native liver will regenerate. And the importance of this is we may stop immunosuppression so that later the native liver we can see here on the left side of our screen. Initially in the HIDA scan, we can see that the auxiliary graft size is larger, but in follow-up, we can see that the native liver has grown here. and subsequently the problems with immunosuppression can be tackled. So this is a novel thing, and we are doing it routinely at our center. So this was one of the kid we got from Oman who came with a hepatitis E associated ALF. He was airlifted and an auxiliary liver transplant was done on day 18 of illness. And subsequently, we can see that within a span of 1 week itself, the liver started functioning normally. So that is auxiliary. Coming on to the hepatocyte transplant, this is a new area which is ongoing. So we extract hepatocyte, we infuse it with the splenoportal axis. It goes and gets implanted in the recipient liver. We can see here in the animation, it's going and getting implanted in the recipient liver. And once it goes and gets implanted, it subsequently repopulates the liver. The issue with this is there are no larger studies. The studies are going on in King's, but there are isolated case reports for metabolic liver diseases in case of viral hepatitis and familial cholestatic conditions like EFICs, in which this has been found to be effective, but a larger study is needed. But in animals, this has been found to be useful for hepatocyte regeneration. So the take-home message from my topic is the definition of ALF. You need to remember that 8 weeks and INR of 1.5 and 2, that two values are very important. Need to identify the treatable causes, which helps the patient to escape from a transplant. Supportive measures, which are essential. ALF and transplant criteria are not the same. Only when we have an INR that is going quite high, a value more than 4, it becomes an indication for a transplant. And identify and referral early to a transplant center is important. Auxiliary transplant is the new option that is there, and it is good. It is equally good. And cell transplant and dialysis are still at the experimental stage. With this, I would conclude my session. Thanks a lot. And any questions?
Thank you, Jagadish, for the wonderful presentation. It was quite elaborative.
Thank you.
There's one question.
Yeah.
In autoimmune hepatitis, how long is steroids continued? Is it lifelong or it is stopped after 4 to few?
Okay, ma'am. You're talking about the total spectrum of autoimmune hepatitis, not specific to the ALF.
No, autoimmune hepatitis.
Okay, ma'am. The consensus, what the consensus says is that first of all, we have to start patient on steroid, and that has to be given for minimum 3 years. So we start on high dose steroids 2 mg per kg. We taper steroids and maintain at a value of 2.5 to 5 mg once daily. And that dosing should be continued along with a second line agent called azathioprine. So these two medicines should be given for a total span of 3 years. We have to ensure after that whether the autoimmune hepatitis activity is normal. For example, if the liver biopsy is not showing any features of hepatitis subsequently, biochemically the child is normal, we may stop these medicines. But statistically speaking, type 1 autoimmune hepatitis, it happens only in 1/3 of the cases. In type 2 autoimmune hepatitis, it is for lifelong. So in case of type 2 autoimmune hepatitis, it is for a lifelong treatment. Whereas in type 1 autoimmune hepatitis, the SMA positive 1/3 can escape in lifelong immunosuppression therapy.
Okay. Next question. What's the percentage of progression of autoimmune hepatitis to acute liver failure? Percentage?
Yeah, ma'am. Total presentation of autoimmune hepatitis, around 10% manifests with acute liver failure, 5 to 10%. That is the total among the total spectrum of autoimmune hepatitis. In India, the most spectrum that we see of autoimmune hepatitis is a decompensated cirrhotic that we see in around 80%. In the West, what they report is 1/3. 1/3 of them can land at acute liver failure. In India, it is roughly around 5 to 10%.
Okay, thank you. Another question, Dr. Jagadish. Have you come across liver complications after giving paracetamol or any other antibiotics in children with hepatitis?
Not yet, ma'am. Not yet. Because see, like in any scenario, like if the child has a viral hepatitis without a liver dysfunction, synthetic dysfunction, it won't matter if we give a routine dose. But there are no studies to mention that a liver failure, if we give acetaminophen, it will worsen. So it like does not have any issue. We can give acetaminophen in such cases.
Thank you.
Another question, sir.
Ah.
Madam, we have 2 more questions. How late can GALD NH present? Gestational abnormal liver disease.
Okay. Okay, so the commonest like clinical presentation of gestational alignment disorder is a neonatal acute liver failure, as I've already told. We know that the hit happens inside the womb, like it's an intrauterine insult. So starting day 1, and majority of the infants, 90% of infants will present within 3 weeks. So greater than like 1 month of life, GALT can happen, GUIDE can happen, gestational alignment disorder can happen, but the incidence is very less. So majority will present within a span of 1 month. Galactosemia, the data is different from India and the West. Usually the clinical symptom starts from 2nd week of life. So that is starting somewhere. The mean presentation in the Western series is around 18 days of life. Whereas from Indian data, the presentation, because initially because of late referral, the presentation was found to be around 50 days. So by that time, the child would have some amount of decompensation by that time. So usually the clinical presentation is 2 to 3 weeks of age. That's in a nutshell.
Okay, Sidhu.
Another question.
Sidhu,
Sir.
can I have a comment? Can you hear me?
Ah.
Yes, sir.
Yes, sir. Yes, sir.
Yeah.
Sir, please.
The,
Please, sir.
Dr. Jagadish, it is a fantastic talk, but
you, sir.
unfortunately, the chairperson has not introduced Dr. Jagadish. Can you please introduce Dr. Jagadish?
Yeah, I already introduced, sir. He's a pediatric gastroenterologist and hepatologist working in Chennai, and a visiting consultant in another hospital.
Devi
Kerala.
Memorial
I
Hospital.
forgot the name.
Yes, Devi Memorial.
Hospital.
Devi Memorial. Madam.
He's in maybe
Maybe Memorial Hospital.
Okay.
Okay, sir. We have 1 more question. Any association between autoimmune hepatitis and IgG deficiency?
Autoimmune hepatitis and
IgG deficiency.
autoimmune hepatitis can be associated with IgA deficiency, but IgG deficiency does not happen. But CVAD, common variable immunodeficiency, is definite association of autoimmune hepatitis. And I would like to just mention one more data. IgA levels, if you do in autoimmune hepatitis, 40% patients will be having a low IgA in autoimmune hepatitis. The implication is that, especially in the northern belt of India, this can be associated with celiac disease. So IgA deficiency, celiac disease, the TTGA can be falsely negative, and there is a link with autoimmune hepatitis.